So should you have an anterior cervical discectomy or not? Well, that one's very easy for me to answer. I don't know. Problem solved. Well, actually not. Let's go a little bit further than that, shall we? Let's talk about how a surgeon thinks about whether he's going to give you an anterior cervical discectomy or not, okay? The first thing you look at is your clinical picture. When they talk to you, take a history. When they examine you, do an examination. Does the clinical picture justify it? Number two, they're going to look at your imaging, your MR, your x-rays. Does the imaging correlate with the clinical thing? And finally, in most circumstances anyway, they're going to see whether you had any non-operative management of this stuff. Because sometimes people get better with non-operative management. So let's look at all of these three together: the clinical, the imaging, and the non-operative management. So let's look at the clinical picture first. Okay, this is taking the history and doing the examination. Remember, you've got your spinal cord in that area and your nerves in that area. If your spinal cord is getting bothered, that's called a myelopathy. And that is generally a quick ticket to the operating room. Nobody wants to mess around with the spinal cord. What's the downside? Obviously, the spinal cord gets irreparably damaged, and then you can't move your arms or legs for the rest of your life. Not a good thing. So spinal cord issues tend to short-circuit a lot of the decision-making and get you right into the operating room. Fortunately, in the clinical picture, much more commonly, you're going to find a nerve being bothered. When your nerve is getting squeezed, that is called a radiculopathy. Radiculopathy. And that typically causes pain, numbness, can cause weakness. You're not going to sit around with a hot radiculopathy because it's going to hurt so bad you're going to go see your doctor. So now you go to your doctor and he's going to want to get some imaging. Say you've tried some non-operative management, not working out. He needs to know what the anatomy is. That imaging typically nowadays starts off with an MR, a magnetic resonance scan of your neck, of your cervical spine. In the older days, they used to do a CT of the neck, which is actually still good if you have a pacemaker. And in the even older days, they used to do something called a myelogram, which isn't done that much anymore, in order to sort out the anatomy of your neck. In addition to that, your doctor will likely get some plain old x-rays, still good for figuring out, for example, whether the bones slip or not. And with that imaging information, the MR together with the x-rays, you'll have an idea of what the anatomy of your neck is, which could impact the treatment plans for you. So now you got two pieces of information. You have your clinical information here, okay? And then you have your imaging information here, okay? And what you're looking for is that area where the clinical information and the imaging information overlap. That's going to hopefully help you figure out what's going on so you can actually treat the problem where the clinical information is explained by findings you have on your imaging. It's the correlation, if you will, of your clinical and your imaging findings that drive the decision making in treating problems with the cervical spine. So now let's talk about non-operative management for these problems. And most of the problems you're going to treat non-operatively are going to be radiculopathies, nerve problems. Because again, your spinal cord issues generally wind up in the operating room sooner rather than later. So let's talk about some modalities, some things we can throw at radiculopathies that might make them feel better. Well, certainly medicines are not a bad thing to think about. Non-steroidals, ibuprofen, that sort of thing. Throw a little Tylenol in there with it. Muscle relaxers may be useful if you don't get zoned on them. Things like nerve agents. Gabapentin is a good drug to try. Steroids. Of course, you don't want to mix these with the non-steroidals. But things like Medrol could be of use. And actually nowadays, although narcotics have been used, people tend to deprecate them. People are using a lot fewer narcotics nowadays because there are all kinds of problems potentially with them. They don't work that well anyway. So medicine is one of the first things to try. In addition to that, you want to try some active therapy like physical therapy. Go see a chiropractor. You might want to get some acupuncture, which works great for some people. Massage. Okay, all these things or any of these things may be of use. Again, keep a very open mind. What else can you do? Well, in addition to having somebody work with you, you can work with yourself. You can get some exercise. In particular, if you're having trouble just bearing weight or being upright, water aerobics works great because it supports the weight of your body there. Some people do yoga, including your author. It works great. Gets your core strength up, and if it's done gently, can be wonderful. I had a person who was a karate person, and they did katas. Didn't spar, of course, but the katas, again, were great for core strengthening exercises. And then finally, as you move up the line, if that's not working too well, you can see a pain management specialist who may have some tricks in terms of medication or possibly injections. Probably the most important thing to remember is to keep an open mind. In addition to that, keep a diary of what's going on, because you'll probably figure it out before anybody else does. And that is the non-operative management of your radicular problems. Okay, so say you've got the clinical problems. You have imaging that correlates with it, okay? You've actually tried the non-operative management for this problem, and it's just not working for you. You've given it a really good shot, okay? So you're winding up in a very small part of this whole Venn diagram universe, and that is a part of the universe where you might think about having an anterior cervical discectomy infusion. So let's talk about that. So should you have an anterior cervical discectomy infusion? Well, let's talk about that. Number one, you should strongly consider it if your spinal cord is getting bothered, if you have a so-called myelopathy. Particularly if that myelopathy is rapidly increasing. You really don't want to mess around. Okay, so that's one circumstance where I would say you probably ought to consider surgery strongly. Second circumstance you ought to consider surgery is if you have a nerve problem, so-called radiculopathy, and you have a good clinical situation, makes sense, you have correlating imaging findings, and your non-operative management is not working, okay? That's a good situation. Also, you ought to consider it if you have a nerve problem which is getting worse. If you're getting weaker and weaker instead of stronger and stronger, think about having an operation sooner rather than later. Okay, so the usual disclaimer, you watching this video does not make me your doctor. Use common sense. If it hurts when you do that, don't do that. And always keep in contact with your own healthcare provider throughout this. So we are all over the web. We have a very active Facebook page with our patients. We are big time tweeters, and we are way into Instagram. To see more videos about anterior cervical discectomy surgery, general spine info, our blog, or to contact us, just hit us at DoctorRodz.com.